there are many better ways of identifying PEEP, just for you to know. Okay, if you are a novice, please don't try fidgeting around with all these things. The first one is a funny graph over there that's supposed to be an animation. Excuse me on that. So traditionally we used to use in the experimental lab something called a super syringe, inflate the lungs step by step using 200 small quantums of tidal volume, see the pressure change, and then plot the lower inflection, plot the upper inflection point, set a PEEP at two numbers higher than the lower inflection point, and make sure you do not cross the upper inflection point. Okay, so this is purely experimental, but again, some of the newer generation ventilators come with this thing called the PV tool, which can actually tell you an approximate number for the lower inflection, upper inflection point. Okay. The next thing what you see over there is a pressure time scalar on a volume control that I already showed you. You see a peak pressure, you see a plateau pressure. Okay. So remember, plateau pressure is going to represent your alveolar pressure. So as you increase the PEEP, keep a watch on what happens to the plateau pressure. You want your plateau pressure to either stay the same or actually reduce. Okay, so when you are improving, when you are recruiting more and more alveoli, you expect the compliance to improve. When you expect the compliance to improve, you want the alveolar pressure to reduce. Okay, so if your plateau pressure is actually coming down with increments of PEEP, that's brilliant. If your plateau pressure is not changing, it's still okay. If the plateau pressure is increasing with changes in PEEP, you need to be a little careful. I've given the formula for static compliance also. So simultaneously with increasing PEEP, you can also look into what happens at the compliance. Now this is again, see, we are talking about resource limited settings. We are talking about times where we don't have enough ventilators. So I'm not going to tell you to all start using this thing called electrical impedance tomography, but basically it's a system where a group of electrodes which you tie across the chest. These electrodes emit small AC current which is being read by a few other electrodes that studies the conductivity and resistance of current and gives you a tomographic appearance to the lung. Okay, this resistance is going to vary depending on whether the alveolar septum are relaxed or stretched. When they are relaxed, they are good conductors of electricity. When they are stretched, they are poor conductors of electricity. So we have a color coding system. Again, I'm not able to show you because I don't have the cursor. I'm sorry. So we know certain colors represent over distension. You can see there in the middle image over there with increasing PEEP, you start having brown areas appearing. Brown areas shows over distension. Somewhere between green and blue is where normally aerated lungs. So this is 1, 2. Let me not dwell too much over here. Remember, this thing exists. This is something which I tend to do a lot more, especially with greater use of ultrasound in critically ill setup. Okay, we can, as we do PEEP maneuvers, we can see, keep visualizing the lung field. In the leftmost panel, I think that says A, you see, we don't even see the pleural line. We see something like there is not much of an aeration happening. The dense consolidation sort of a picture is there. Okay, I'm sorry. Again, it requires a little bit knowledge about lung ultrasound, how the lung picture looks, what is an A profile, what is a B profile, all of those. Okay, but I think you can appreciate how the images change between the panel A, panel B, and panel C. Panel C is where you start seeing the pleural line. For those who can identify, the pleural line is seen, and you start seeing what are known as a B profile, the B lines, the straight vertical lines which you are seeing starting from the pleural line all the way below. Okay, so this shows that we have recruited the lung. There is some air going in and coming out. Of course, B represents a wet lung. Okay, so when you see this transition, you know that you have recruited the lung. Yeah, this is, so ultrasound can also be used. This I'm not going to dwell into it. Okay, this is something called trans-pulmonary pressure, which is actually the distending pressure for the alveolus, better than the P plateau or better than anything else. Basically, esophageal pressure is to be measured as a surrogate of pleural pressure. From that, we identify what should be the suitable PEEP which will prevent alveoli from collapsing. Okay, I leave it at that. I'm sorry. The simple formula is transpulmonary pressure is airway pressure minus esophageal pressure. Now, at end expiration, that is at the end of expiration, that airway pressure will be substituted by the PEEP value, and the esophageal pressure is what we measure, and we want it to be 0 or more. When something is less than 0, the tendency is for the alveolus to collapse when you have a negative value. When something is 0, the alveolus is still open. When something is slightly more than 0, 1 or 2, the alveolus tends to remain open. So the target of transpulmonary pressure at end expiration should be to have a value of 0 or 1. Okay, I'm leaving it there. I told you I'm just going to give you a glimpse of all this, and Shrishti is already frowning at me. I think I'm going to extend into her time, right? This is another thing which many of y'all may have, something called the stress index. Okay, there are multiple images. Look at the leftmost, the user interface of a ventilator. I put 2 circles over there. If you look at the right panel circle over there, it shows you a number for a stress index. I think it says 0.90. Okay, so basically stress index tells you the tension of your alveoli. You want to have a number of somewhere between 0.9 to 1.1. Okay, it's okay even if, so you will titrate your PEEP up or down to target a value of somewhere around 1. 1 is what we desire to have. Okay, something that is less than 1 means to say that the alveolus is collapsed, or something which is more than 1 means to say that the alveoli are over distended. Now don't worry, even if your equipment, if your ventilator does not have the algorithm or the software to tell you the number, just look at this pressure time scaler. Again, on the right hand upper image, I've given you 3 examples. 1, 2, 3. The one in the middle, look at the one in the middle. Just look at the tracing. It is a linear upstroke. This is what is favorable. Okay, normal lungs, you have a linear upstroke of the pressure time scaler. Now focus on the one to the left of the middle. You see something like a convex up. The one on the right is a concave up. Okay, when you don't want to see either the left or the right panel on your ventilator, you want the middle one to be displayed. Okay, so when you see the one on the left, it means your alveoli are still collapsed. You can go up on the PEEP a little more to try and bring it to this middle kind of a picture. When you see something like on the right side, the concave up, you need to come down on your PEEP because your alveoli are already over distended. Try to bring it somewhere close to this. Okay, I've also given pictorial representation of the alveoli underneath corresponding to the graphs. I hope you can make it out, right? And with this, I would stop the PEEP stuff. Something that has been tickling us all a lot in the last 4 years from 2016, that is this driving pressure or the delta PEEP, basically given by the difference between plateau pressure and a PEEP. Okay, now you can set PEEP simultaneously looking at what happens to this delta P. Again, I repeat, delta P is nothing but the difference between P plateau minus PEEP. Your maneuver should preferably reduce the driving pressure or the delta P. Okay, whatever you do, your increase in PEEP or decrease in PEEP, your target is to reduce the driving pressure. Okay, now look at the graph here. You can see 3 things happening. Number 1, 2, 3. Okay, in 1 you see the upper line denotes the plateau pressure, change in plateau pressure. The lower line denotes the PEEP. In the first image, you see that the delta P or the gap is actually increasing. Okay, that is not something that you want to happen. That is the worst thing you can do to your lung. Look at the corresponding mortality straight below. You see when the delta P actually keeps increasing, your mortality also keeps increasing linearly almost. Now look at the middle panel. The upper line is the P plateau, lower line is a P peak. Whatever your change in the PEEP is not actually changing. The difference between these two is remaining constant. It's not too bad to have this situation, because if you look at the corresponding mortality panel below, mortality actually hasn't changed much. But the best case scenario is the last one, the rightmost. You see that an increase in the PEEP actually shows a decrease in the driving pressure. Again, I'm repeating, difference between P plateau and PEEP. And look at what happens below. The panel that tells you the mortality, it linearly goes down. Okay. Now, which is the paper that showed us this? This particular one that came up in 2016, basically it was a retrospective paper looking at all the available ARDS network trials. I think 9 of them. They did some statistical analysis and they came up with this finding rather. Okay. Now I'm just leaving you all at that. Okay. These are all different ways of titrating your PEEP. When you do your PEEP titration, look at all of these, but have PEEP FiO2 table as a starting for the novice.